Hello, I'm Dr. Jenny Andrus, and welcome to Joint Ventures. In this OSC original podcast, we take a look at recent medical news and headlines. We know medical news can be difficult to understand, and it's hard to know which sources you can trust. And who honestly has time to read through all this information anyway? Well, lucky for you, my friends, we now have this podcast where we're taking deep dives into the latest science. Our goal is to review the latest medical news and trends in a non-biased way and present it in a format that's understandable. If you're new to this podcast, welcome. We are so happy you tuned in. For those of you newcomers, I'm an interventional pain management physician at Orthopedic and Spine Center in Newport News, Virginia. And as you can probably guess, low back pain is the biggest problem I see in my practice. Back pain is, honestly, it's one of the top 3 reasons people go to the doctor in the first place, much less a pain doctor. Despite being extremely common, it can still be very resistant to treatment. And it takes a village sometimes to really get at the cause of back pain. And so I'm so excited today to have Dr. Tom Toothaker with us. He's a doctor of physical therapy and as such is a true expert in the muscular disorders of the spine. Now, we hear so much about disc disease and spondylosis, arthritis, all these causes of back pain, and the muscles seem to get forgotten. And a lot of doctors tend to think of weak muscles more as a symptom of back pain as opposed to the cause. So is your back weak because of your pain, or do you have pain because your back is weak? Chicken or the egg, right? So to help understand this, let's look at the spine muscles a bit. The muscles surrounding and attaching to the spine are called paraspinals. They're responsible for moving and stabilizing the spine. They are the source of the majority of a load that the spine's soft tissue, that's muscle, tendon, ligament, and they are crucial for proper functioning of the spine. So as you can imagine, when the spine is degenerated and the discs are flattened and the joints are arthritic, these muscles become sort of your last line of defense in accepting that mechanical load. Now, Dr. Toothaker, how do you explain paraspinal anatomy and its importance to your patients?
Yeah, so first, I appreciate the opportunity to sit down with you. In our working environment, we don't really get the opportunity to do this face-to-face, so I'm excited about this. All right, so everyone has heard of the core, okay? So let's break that down and talk about what that means. You are built in layers of muscles, okay? So your most superficial layer, this is the one that you can see on the outside after you take the skin off, is your latissimus dorsi. Now, a lot of people think of latissimus dorsi, or your lat, is just this piece of muscle right here, okay? But this muscle is huge. It attaches at the lower bottom part of your shoulder blades, comes around, attaches at the front part of your arm. A lot of people don't understand that. And then it comes down into a V shape into something called your thoracolumbar fascia. There are also multiple muscles that attach in that region, okay? That constitute the core. So you have something called your internal external obliques. They'll run just like this, like an overlapping pattern on the sides of your body, okay? And you have something called your transverse abdominis that wraps around just like a belt. So when all these muscles contract together, they make up your core, okay? Now, and there's other muscles involved as well. So we take those, pull those away, our next deepest layer. These are your longissimus, your iliocostalis, and your spinalis muscles. These collectively are called your erector spinae muscles. They run from your hips, your lower back, your sacrum, and they travel all the way up your spine, up to your neck, cervical spine, and the back part of your head. Now, when they contract unilaterally to one side, right, they bend your trunk. When they contract bilaterally, same time, they'll extend your trunk. These muscles, along with other muscles, are involved also in maintaining your posture. Now, your most deep layer muscles, okay? These ones live right at the spine, right? So they are right on and in between the vertebrae, which is the bone that make up your spine. So you have your multifidus, you have your rotatories, and you have your interspinalis muscles, okay? Now, what's of most importance here, I mean, they're all important, but what is pretty unique is the multifidus, right? Multifidi muscles, right? They attach at the second to fourth vertebrae above where they originate, and an overlapping pattern all the way up from your lower back all the way up to your cervical spine. So they also assist with extending the spine, rotation, okay, and side bending, but they're most known for their ability to improve and engage spinal stability. All right, so there's our anatomy lesson, okay? Now, there are changes in these muscles with lower back pain, all right? In these patients, we'll see an increase in fatty infiltrations. Basically, there's literally fat in the muscle, okay? Fibrosis, which is a tough connective tissue, that again is in the muscle, and atrophy. Now, atrophy doesn't necessarily mean, doesn't mean a decrease in the amount or the number of muscle fibers, but a decrease in the size of those muscle fibers. So they'll shrink, they'll get smaller. And when that happens, that'll reduce the body's ability or the muscle's ability to generate force, and then of course reduce its ability to stabilize the spine.
Yeah, definitely. I see changes that are really quite severe in my patients' MRI scans in their paraspinal muscles. I mean, and you can pull them up and you can really show patients just how white it looks, and compare it to different levels. I'll show them, let's look up high and look down low. And not only do you see that the muscle is smaller, but it's white because it's infiltrated with fat or fibrotic tissue. And studies do show that having more paraspinal atrophy or fat infiltration is predictive of back pain at 1-year follow-ups.
Yeah, it makes perfect sense. Now, what we're saying, I typically don't go into this much detail when I'm talking to a patient. So typically what I'll do is what we're discussing is called the pathoanatomical model. So you've got anatomy, right, which was what we described, which will lead to a certain pathology, right, some type of issue that you have, okay? And this is a model that we've used for a long, long time, and it's still used today, and it can describe some issues for sure. But we've kind of transitioned more towards using like pain science language to describe the situation and more of a biopsychosocial model, okay?
Say that 3 times fast.
Biopsychosocial, So yeah, I had to say it actually a million times before this because I kept messing it up. Anyway, I said it really good the first time here. So let's break that down. And first, what we found is there's a larger determinant of your rehab potential through this model, okay? So this is your genetic makeup. You have these overlapping systems in your body, which there can be issues with that can contribute to your symptoms, stress, anxiety, depression. We have things like your socioeconomic factors. We have relationships and your family support, okay? So with these, and then with the words that we use, these words such as degenerative changes, arthritis, bone spurs, like these create panic, okay,
sure.
Right, in our patients. And so what do? Now they feel like they've got to walk around with bubble wrap, or they feel like they're gonna break into pieces, okay?
Yes, right.
So what I'll do is I'll typically reference, like you've seen this, there's multiple studies that have shown, all right, you've got 3 images, right? We'll say 3 MRIs, okay? You've got this one over here, and I mean, it's got a significant decrease in disc space, there's arthritic changes, there's bone spurring, they might even have a curvature, scoliosis in their spine, and you meet that person, you would think, wow, this person's really bad off, okay? And they've got some pain, they're stiff, some immobility, but for the most part, they're doing okay. Doesn't seem to match up. Then you've got the one in the middle, right? So there is some decrease in disc space, some arthritic changes. They're in some pain, it affects their daily life, but they're getting around. Then you've got the image that for the most part, it's pretty good to go, okay? But yet they're in pain, they're ready for surgery tomorrow, right? So it doesn't always add up. So you have to take the person in front of you and match that with the clinical signs that you have with the imaging. So what I'll typically tell people is, okay, because they'll tell me, all right, so hey, Tom, did you see my X-ray? Really bad off. They told me I've got degenerative disc disease. I'm like, wow, okay, yes. So your body has made some changes, okay, that's occurred, all right, but your body is still very strong and still very resilient.
That point that you just made is so important. There is no MRI changes that are predictive of the development of chronic pain. Super important. Patients really, as soon as I say to them when I come in the room, hi, nice to meet you. What's going on that I can help with? I have degenerated disc. Well, so do I, so do you. There's nothing no study has shown that an MRI scan can predict chronic pain. So it's much more complicated, which is why we have jobs. Right?
Exactly.
But obviously we're going to want to strengthen and condition those muscles that we talked about earlier with exercise, right? Those last line of defense muscles. But when a patient's uncomfortable, they don't want to do it, right? It hurts, you don't do it. Kinesiophobia, big name for something we all have, right? How do you get patients through it?
Yeah, so it definitely can be a tough situation, but it is doable. All right. So we have multiple mechanisms, or proposed mechanisms, that we think that can help with people with chronic lower back pain. So we have the gait control theory. We have reduction in central sensitization. We have activating the most deepest layer of your musculature. We have endorphin release, all right, and then increasing blood flow to that area. Right. Many things can do that. Physical therapy programs have shown improvement in chronic lower back symptoms through a lot of these proposed mechanisms. All right. So now I'm going to ask for a hall pass here. Okay. So I'm going to describe I'm going to describe the pain response, and I'm going to skip a lot of steps. And it's not going to be very technical, so don't judge me. Okay. All right.
No judgment.
So all right. So you have several receptors throughout your body. Okay, and they're modulating incoming and outgoing signals. Okay, and so in an effort to keep your body in homeostasis, right, to make sure everything is good to go. All right. So when one of these receptors feels or sends a signal of pain, okay, it then takes your body out of that homeostasis, all right? So this signal will then travel to the spinal cord, and a lot of times it'll stop right there if it's something that's acute and needs a response right then and there, right? Think of like when you touch a hot stove, right? It'll go to the spinal cord and then right back to your hand to pull it away, okay? Now, there are other tracks that then go all the way up to the brain and then send a signal back down towards the target tissue, okay? So let's take an example of somebody who bent over to grab something from the ground and there's a sudden onset of pain, right? So what happened there? Target tissue sent a signal to the spinal cord, up to the brain. Brain went back down to the target tissue and said, contract, stiffen, okay? Because it wants to eliminate the potential for further insult into that area.
Protection.
The protection, exactly, right? It's the defense mechanism. So the patient, what do they tell you? They tell you typically, I bent over and my back just locked up on me.
Seized
right?
up, locked up.
Seized up, locked up, right? So now, this is okay, right? That patient or that person can usually get through it, but here's where there's a problem, okay? Is when, if that goes on long enough, that patient feels the pain, they move less. They move less, they feel more pain. Now we've created a negative feedback cycle. Now, what people don't understand is the pain does not always equate to damage, okay? So what we've discovered over time is we actually want that person to gradually and slowly move into the painful position, okay? So what happens is the patient moves a little more, they feel a little better. They feel a little better, they move a little bit more, okay? Now you've desensitized the tissue and you've created a positive feedback loop.
Now, interestingly, kind of piggybacking on that, there's a relatively newer treatment that can target that multifidi, that deep area in the paraspinals where you have that inappropriate feedback loop, and it's called peripheral nerve stimulation, or PNS. Really excited about it. It's something relatively newer that we're doing at OSC now. But what you're doing is you're taking a very, very thin, I mean, you can hardly see it, wire, and you're placing it within a couple centimeters or so of those multifidi nerves, and the nerves to them called the medial branches. And what you're doing is you're stimulating that, and then this pulse is actually repairing that inappropriate feedback loop, that sensitization that has happened as a result of that injury. It's left in for about 60 days. It's not something that's permanent, but really interesting showing this desensitization process is that after this is removed, most patients still have very significant improvement in their pain a year out, like a year after this thing was removed. So clearly there is some inappropriate change that has happened at the spinal cord level, probably, and even more likely in the dorsal root ganglion, where all this information comes into the spinal canal. And that pulse helps to rewire that or unscramble that. So it sort of gives further credence to this idea that these muscles aren't just stabilizing, but they're proprioceptive and also important for the development of chronic pain.
Yeah, so very interesting, because there's definitely situations that arise where the pain is too acute, the tissue is too hypersensitive, and the patient just can't move, right? They can't do anything meaningful to actually engage in exercise in a physical therapy program. So I guess through those mechanisms that we discussed earlier, if we took PNS, use that to significantly reduce the pain in the patient, we could then get that person to a skilled physical therapy program and start to reintroduce movement through mobility and resistance exercise.
For sure. And the models for that now are incorporating physical therapy and movement after that initial acute pain calms down with the PNS system. So certainly in the future, I will be co-treating in that way a lot more.
And that's what makes sense, right? You have to reduce the pain, but then you have to actually increase the muscle mass, strength, and mobility. And there's no reason why a connection like this shouldn't be made for that patient. You know?
Absolutely. Absolutely.
All right. So now that we have that established, let me take you through a typical routine or typical program that I'd put somebody through once we've been able to reduce that pain. So typically we'll start with isometric exercises. All right. I'll have a person lay on a table. They'll have their legs slightly bent, and I'll have them learn how to brace their midsection. So learn how to tighten and brace the trunk. Once they've got that down, I'll then put them in a different position, a little more challenging. They'll put it maybe like hands and knees, and now they have to brace in that position. After they do that, I'll introduce some movement. So maybe they'll extend their leg out, hold it for a few seconds, come back, do the same thing on the other side, and then make it a little harder. I'll then have them extend an arm and a leg, okay? So isometrics are a great place to start when it comes to helping reduce pain and getting the person more comfortable with contracting the muscle tissue. Now, from here, we also want to look at the painful movement. So if there is something so we'll take our example of our person earlier. They bent over, felt pain, didn't want to move, okay? So I'll take that person and I'll put them in a chair in a sitting position. I'll put a ball in front of them, stability ball, and or their coffee table, and I'll have them just slowly bend forward, right? So they have a supported position. They can support their muscle tissue as they move forward. I want them to go into that painful position just a little bit, right? Feel some discomfort. You've got to stress the tissue for the tissue to change, okay, right? So over time, that'll increase their motion. Before you know it, they have full motion or close to it. I'll take the actual stability away, and now they have to do it on their own. So I'll have them put their hands on their chest, and then now they have to use their own musculature to guide themselves down. Again, starting with a small motion, increasing over time, and then eventually I'll have them stand and do the same thing. And then most importantly, I'm then getting them to functional strength movements, okay? Now I'm talking deadlifts, I'm talking sled pushes, farmer carries, suitcase carries, and I said deadlifts, okay?
He did not just say deadlifts.
So, I mean, 70s, 80s, 90s, I've got people doing these movements, okay? So you can't be scared of them. And you got to think, what do you do in your life, right? You carry groceries. You have to pick things up off the floor, right? If your capacity is so low that you can't do these things, right, that's where pain occurs, okay? So if you train the systems in those ways, it's going to help you with everyday movement. So some time ago, there was research that came out that showed there was a decrease, which we kind of talked about earlier, in the activity of multifidus and transverse abdominis with chronic lower back pain, right? And so what PTs did back in the day is they'd have them lay on the table, like I said before, and we'd put a blood pressure cuff under their lower back, or we'd put our hand in the lower back, okay? And their goal was to be able to contract the tissue without the needle moving on the blood pressure cuff. And then we knew, okay, they knew how to contract their TA, all right?
That's hardcore.
Hardcore, right? All right, so, but here's the thing. They couldn't move on to phase 2 until they completed that. So I've got somebody moving the needle, and now we're in week 3, and we haven't gotten off the table yet. Are you kidding me?
Yeah.
Right? So we've got to move on to the next step. All right, so we also, throughout the years, we've had more research come out that has shown a specific core-centered program is no different than generalized low back strengthening, okay? So in my experience, what I found is incorporating a multi-joint strength program is gonna give the best results. Now, do I not do low-level core exercises? Of course I do, okay? I do them all, but here's the thing. You've got to take the person in front of you, and you do a combination of the best exercise for that person with the eventual goal of getting to those higher level movements, all right? So honestly, you know, I strongly believe that there's 2 reasons why physical therapy doesn't quote work, or people have said it's failed them with this type of situation. One is the person didn't do the program consistent enough for a long enough period of time, okay? And or the physical therapy program did not progressively overload over time with enough intensity.
An important thing to note there too is what is your expectation for the patient, not just the provider, but the patient, for what they're going to get out of physical therapy.
True.
And a lot of patients will tell me my pain did not improve. And sure, I want your pain better. I'm a pain doctor, for crying out loud. But the main thing I'm actually looking for in physical therapy is all the stuff you just talked about. Functional restoration. Can you bend over and tie your shoes? Can you bring your groceries in, or do you have to call someone to do it for you? Those are the things that actually show improvement in physical therapy. And I think you're hitting the nail on the head of what we're looking for. The pain is secondary. The movement is primary.
Man, see, this is why we need to talk more. I'm not kidding, because literally that is the exact same speech I'll give people. It's like, listen, you've been in chronic pain, you've been in this for a long period of time.
Right.
I was like, if I can't help you with your pain, I can at least get you stronger and you can function better.
Yeah.
And spot on.
Yeah, trade secrets here at OSC. Well, thank you guys so much for joining us. We hope you learned something. I did. I got a great refresher on anatomy from Dr. Toothaker. Please subscribe. We don't want you to miss out. We're always making new content for you. Thank you so much. Wishing you good health. See you soon. Bye.
At Orthopedic and Spine Center, we're dedicated to providing the highest quality treatment using the most advanced technology available. Our fellowship-trained spine and interventional pain management physicians specialize in diagnosing painful conditions and offer minimally invasive interventions to complex spine surgeries. Our pain psychologist helps patients understand and reduce stress from chronic pain conditions. Our experienced physicians get you back to doing what you love. Call today for an appointment. Experience excellence at Orthopedic and Spine Center.